statement.
Thank you, Madam Chair. It's great to see that this meeting is being held. Before my days here in Washington, I actually ran a company called My Health Card, which was electronic medical records that people carry around in their pocket. A company that we found very difficult to get off the ground, very difficult to get the hospitals, their programs, whether it be GE Medical or whether it be iPath or whether it be any of the major electronic medical record groups to get you to do an interface with their systems. But we did find a company that allowed us to do that. And in relationship with the University of Tennessee's medical system, we actually worked with the geriatric population. We gave them all their cards for free. The hospital used it more as a marketing tool, but we realized in a very short time that it actually saved lives. So there was a small, wasn't a chain pharmacy, but it was actually a pharmacy that allowed us to be able to put the database into their system. So a person would go to the primary care physician. That information was then, because the systems was downloaded onto the card, had a 119-digit encryption code, HIPAA compliant, and then the person would go to the pharmacy. The pharmacy then would be able to only look at the information that the doctor put on the med sides. And we found out, we saw drug interactions. They went from their primary care physician to a specialist. The specialist had no idea what the primary care physician had prescribed. And we saw numerous times of drug interaction. It was caught by the physician. He then had the phone number because it was time-stamped and dated on the card. And they recognized very quickly that they had a problem. And in the geriatric population, we saw a decrease in days in the hospital, times in the emergency room was significantly dropped. The hard part that we had was because of the interfaces with the big companies, if you will. They wanted to capture that data. We had other problems with pharmacies to be able to allow the other pharmacists. They wanted to capture that data. They wanted their data for their own personal. We didn't look at it. We didn't care about the data from the standpoint of what meds were being taken. We just want to make sure that the health and the care of the patient was taken care of first and foremost. And then we realized that the hospitals actually had no idea what was happening internally with their hospital. When a person comes to the emergency room, because they outsourced their emergency room, that information technology system was different than the one that they have inside the hospital. Then they go to an operating room. Well, the OR software is different than the outpatient surgery software. And so you had no way to communicate within the hospital. So we found ourselves having to implement interfaces with all these systems. By the time we got one interface completed, we had to then start all over because it was time to complete the interface again. So we went through a complete circle of finishing the interface, and by the time we got it done, in order to make the card work completely throughout the hospital, we were forever doing an interface, and that costs money. So I commend you for being here today and talking on some very important subject. We actually, one of the most important things we was able to do with the company, it seems like we do our philanthropy work more than anything, is kids with foster care. The child would go from place to place to place. The medical records was never with them. And so this card they can take with them. So, Madam Chair, I thank you for holding this very important. It's a way to cut down costs of our overall medical crisis that we're in. And I think this is going to be a very important part of making a difference in health care. Thank you, Madam Chair. And I yield back.
Thank you. And now it's my pleasure.